Let's jump straight into the test day decision logic for connective tissue diseases, starting with the master autoantibody rules. Okay, this maps out exactly how you beat the sensitivity versus specificity trap on step 2 CK. You're going to use ANA as your sensitive screen. It casts a huge net, right? So if it's negative, you can basically rule out SLE. But a positive ANA absolutely does not equal lupus. It's just your green light to keep digging. To actually confirm SLE, you need anti-dsDNA and anti-SM. Boom, specific. Now, lock the rest of these into your memory. Antihistone is your dead giveaway for drug-induced lupus. Anti-SCL70, that's diffuse systemic sclerosis, whereas anti-centromere points to limited systemic sclerosis. And hey, while we're on systemic sclerosis, watch out for scleroderma renal crisis. It's a massive step 2 emergency. Sudden severe hypertension, papilledema, microangiopathic hemolytic anemia, acute kidney injury, you have to treat it instantly with ACE inhibitors. And remember, lung involvement is still the most common cause of death for these patients. Back to the antibodies. Anti-Jo1 suggests inflammatory myopathy, and anti-CCP is your flashing red light for rheumatoid arthritis. Finally, nail down your Sjogren's syndrome markers, anti-Rho/SSA and anti-Law/SSB. Look for these when a patient has keratoconjunctivitis sicca, dry mouth, and enlarged salivary glands. Also keep in mind Sjogren's carries a huge risk for non-Hodgkin lymphoma. You'll objectively measure tear production with the Schirmer test. Don't confuse this classic presentation with benign age-related sicca, which is just an older patient with mild dryness, near normal secretory function, and totally negative autoimmune markers. So what does classic SLE actually look like? Here's your recognition framework. When a test question describes a young woman presenting with a malar or discoid rash, severe photosensitivity, oral ulcers, and a bunch of systemic issues like pleuritis, pericarditis, cytopenias, renal disease, or even scary CNS stuff like seizures and cognitive dysfunction, anchor your diagnosis right on SLE. It's the ultimate imitator because those immune complexes get deposited everywhere. But this specific clustering of multi-organ chaos in a young woman, that's your signal. Now, don't let the MSK presentation trick you. Examiners absolutely love testing if you can tell SLE arthritis apart from rheumatoid arthritis. SLE arthritis is often asymmetric and migratory, so yeah, it sounds exactly like RA at first glance. But here's the catch. SLE arthritis is uniquely non-erosive on X-ray, and the morning stiffness is super brief. If that stiffness lasts for hours and you're seeing actual joint destruction or erosions, stop thinking lupus and pivot straight to RA. Let's build this into a foolproof diagnostic flow. Step 1, screen with the highly sensitive ANA. If it hits positive, move to step 2, confirm it with the highly specific anti-dsDNA and anti-SMEM. But your job doesn't end at diagnosis. Step 3 is tracking. You're going to monitor disease activity and the risk for lupus nephritis by keeping a close eye on anti-dsDNA titers and complement levels. Sticking to this stepwise logic means you won't jump the gun with unnecessary tests. This right here is a classic fork in the road. A known lupus patient rolls into the ED crashing with a fever and severe symptoms. You have to figure out, is this an immune flare or a hidden infection? Check those complement levels. If they're low, that screams immune flare because the complement proteins are actively getting chewed up by a massive storm of immune complexes. On the flip side, complement proteins are acute phase reactants. So if the patient actually has an infection, those levels will rise or at least normalize. Let's talk kidneys. Lupus nephritis is a massive driver of mortality, and the clinical algorithm here is totally rigid. You must screen with a urinalysis. It's non-negotiable. If that UA shows red blood cell casts, hematuria, or nephritic range proteinuria, you have to do a kidney biopsy. You can't just guess the severity from blood work alone. The biopsy is critical because it tells you if you're dealing with active inflammation or irreversible scarring. And that matters because you definitely don't drop heavy immunosuppressants on dead, scarred tissue. Always match the drug to the damage. Hydroxychloroquine is your foundational baseline med. It cuts down overall flares and specifically targets the arthralgias, serositis, and skin issues. You keep NSAIDs around for basic symptom control. When acute, mild to moderate flares pop up, short-term prednisone puts out the fire. But if the disease goes after a major solid organ, like in severe lupus nephritis or central nervous system involvement, you've got to bring out the big guns like cyclophosphamide. Moving on to a really high-stakes scenario, an SLE flare during pregnancy. Pregnancy is basically a massive stress test for the body, and it can totally trigger a severe lupus nephritis flare. Clinically, you'll see edema, a malar rash, and arthritis. But the real danger signs, they're hiding in the labs. Look for hematuria with red and white blood cell casts, plunging complement levels, and skyrocketing ANA titers. these patients are at huge risk for preterm birth, fetal growth restriction, or even fetal demise. Which brings us to a diagnostic dilemma you are absolutely going to face. How do you tell a pregnancy flare from preeclampsia? It's all about those classic immune markers. An SLE flare is driven by immune complexes, right? So you'll see RBC casts, low complement, and high ANA, plus joint pain and rashes. Preeclampsia, on the other hand, is a vascular and placental problem. It shows up primarily as new-onset hypertension and proteinuria after 20 weeks, and completely lacks that classic immune flare lab pattern. Okay, what if your patient doesn't fit the classic young female demographic, but suddenly develops lupus-like symptoms? If they recently started taking procainamide, hydralazine, penicillamine, minocycline, isoniazid, or a TNF-alpha inhibitor like etanercept, pivot straight to drug-induced lupus. They're going to present with acute fever, malaise, arthralgias, and serositis. Interestingly enough, that classic lupus rash, it's actually way less common here than an idiopathic SLE. Your golden ticket for diagnosing drug-induced lupus is finding positive antihistone antibodies. They show up in over 90% of these cases right alongside a positive ANA screen. Another massive clue that you're dealing with a drug-induced form rather than classic SLE is the total absence of severe renal or central nervous system disease. Once you spot this, the fix is easy. Just stop the offending medication. Let's shift gears to another critical algorithm, antiphospholipid syndrome, or APLS. The rule here is incredibly strict. One clinical criterion plus one lab criterion. You cannot diagnose this just on labs. The clinical event has to be a vascular thrombosis, arterial or venous, or a severe pregnancy morbidity. Think 3 unexplained early fetal losses, 1 loss after 10 weeks, or a premature birth before 34 weeks due to severe preeclampsia or placental insufficiency. You pair that clinical history with one positive lab, the lupus anticoagulant, anticardiolipin, or anti-beta-2 glycoprotein I. And this distinction right here is a literal lifesaver. The Step 2 emergency rule for pregnant patients with known APLS is that they must be managed with a combo of low-dose aspirin and heparin. Warfarin is strictly 100% contraindicated during pregnancy because it causes severe birth defects. Knowing this exact pharmacological switch is mandatory for both test day and real life. Finally, what if a patient walks in with a really messy, confusing overlap of symptoms that just won't fit neatly into one box? You're likely looking at mixed connective tissue disease. It's this chaotic autoimmune blend of SLE, systemic sclerosis, and polymyositis. You'll see swollen, puffy hands, signs of inflammatory myopathy with elevated CK, pulmonary hypertension, arthritis, and the intense cold sensitivity of Raynaud's phenomenon. And speaking of Raynaud's, you've got to know primary versus secondary for the exam. Primary Raynaud's usually hits young women, normal nail fold capillaries, negative ANA and ESR, and no tissue damage. Secondary Raynaud's, like what we see in MCTD, usually hits men over 40, comes with abnormal nail fold capillaries, actual tissue injury like digital ulcers, and a positive autoimmune workup. So, what's the definitive, non-negotiable diagnostic marker you must select on test day to confirm mixed connective tissue disease? It's the anti-U1 ribonucleoprotein antibody. When the clinical picture is just a chaotic overlap of a dozen different rheumatological symptoms, this highly specific autoantibody is the key that cuts right through the noise. It secures your diagnosis. When a patient presents with a maze of overlapping issues, don't get lost in the ambiguity. Let the precision of targeted autoantibodies reveal the true underlying disease and guide your next critical move.